Thank you for joining us for this conversation on early detection and screening, and thank you to GSK for making this session possible. Why don't we have an early detection test for ovarian cancer? Will we ever have one? Should everyone be screened? Questions around these issues are among the most top of mind for so many in our community, and we put together a great panel to tackle these issues. The panel today includes Audra Moran, President and CEO of OCRA, Dr. Deborah Armstrong, Professor at Johns Hopkins University, Dr. Philip Castle, Director of the Division of Cancer Prevention at the National Cancer Institute, and Annie Ellis, an ovarian cancer survivor and research advocate for OCRA. Thank you all for joining us for this important session.
Hi, everyone, and welcome. I'm Audra Moran, President and CEO of Ovarian Cancer Research Alliance. Thank you so much for joining us today for what promises to be a highly informative and interesting session. Finding a method of early detection for ovarian cancer has been a primary focus of research for years, and it was believed to be a promising approach to stop women from dying of the disease. Under this umbrella, symptom awareness is also often cited as important for changing outcomes. Some other cancers have demonstrated that earlier stage diagnoses can lead to better outcomes, and a statistic we hear a lot has been that when caught in stage 1, the survival rate for ovarian cancer is over 95%. However, this stage-related survival statistic can be misleading, and recent research has revealed that the reality for ovarian cancer is not as straightforward. Recognizing that this is really confusing and understanding the need for us all to be on the same page, we've convened a panel of experts to help guide us through the current landscape related to early detection. Today, we have a great panel to discuss these topics. Dr. Deborah Armstrong, Professor of Oncology and Obstetrics and Gynecology at the Johns Hopkins Kimmel Cancer Center, Dr. Philip Castle, Director of the Division of Cancer Prevention at the National Cancer Institute, and Annie Ellis, a long-term ovarian cancer survivor and research advocate. Thank you all for being here today. I know this topic is important to all of us. Would you each mind briefly sharing why understanding the nuances around screening for ovarian cancer is important to you? Maybe Dr. Armstrong, we'll just start with you.
Thanks. Yeah. I'm a medical oncologist and I treat breast and gynecologic cancers with a specific focus on ovarian cancer, but also on cancer genetics. So I frequently see women who are at increased risk for ovarian cancer, and trying to guide them in terms of what the right approach is to assessing their risk and managing it is really critical. And there's nothing that seeing patients and their families like this and not having the tools that we would like to have for early diagnosis and, more importantly, prevention.
Okay, well, thank you. Dr. Castle?
Yeah, so hi, everyone. My name is Phil Castle. I lead the Division of Cancer Prevention at the NCI. Prevention is near and dear to my heart. I lead this fabulous division that's focused on prevention of all cancers. And really, it comes down to nobody wants to get cancer. I mean, that's the bottom line. If we walk down the street and we say, would you rather have your cancer prevented or treated? Everybody's going to say prevented. So I would say that ovarian cancer has been a real thorn in our side in terms of trying to come up with better strategies. And the NCI is devoted to helping that research along so that we can provide an answer soon.
Great, thank you. And Annie, how about you?
Yeah, I think it's all about protecting the next generation, getting a cancer that nobody wants to have, being in a club nobody wants to be in. How do we help others not be here? I really am interested in protecting my sister and my daughters. And now that I have a granddaughter, it's even more urgent. And I know other patients like me feel the same way. We want to protect other people from having to deal with this.
Great. I think we're all here for the same reasons. So let's get started. First of all, can we just start with some definitions for clarity? It gets a little confusing. We use a lot of different terms. So there's often some confusion between the terms screening versus early detection and detection versus diagnosis and monitoring. Can one of you tell me the difference?
Here, let me take that one on to start with, and hopefully Deb and Annie can chime in. So screening is sort of a general term, and we apply screening to generally healthy people. I would say early detection is a subset where we don't find, let's say, precancer, we find cancer, but find it earlier. So that's sort of an easy operational definition. Screening can prevent and also can early detect. Early detect is just finding the cancer earlier.
That helps. And then what about detection and diagnosis versus monitoring?
Well, that's, once you've been diagnosed, then you're in this other realm. And that realm is how do we monitor the effectiveness of treatment, and how do we catch recurrence as soon as possible, so that we can act with the next line of therapy.
Okay, great. Anybody else? Okay. Annie, do you have some questions? I think you did.
Yeah, because I think a lot of times, when I was very early in my, journey, I would get, of course, screening and a test for early detection, mixed up. So it's really helpful to have this. And I also kind of think about, when we find things, we hear like, is there already a mass or not a mass? And so screening is when there is no mass, is what I'm hearing. And then early detection, to me, as I'm learning, is early enough so that you can have an intervention that, something can be done. And so I guess we'll hear more about that later. I'm jumping ahead and I'm sorry about that. Can I?
That's okay. No, I think you bring up a good point about CA-125, though. We hear all the time, why can't you just screen for CA-125 in the general population? I mean, a lot of people ask that question. Dr. Armstrong, do you have any thoughts on that?
Sure. First, I just want to define a little bit about how we define risk in our population. In the United States, the average risk of ovarian cancer is 1 to 2%, so it's not a terribly common cancer. But there are populations of women, specifically women who have a family history and are known to have a gene mutation that increases risk, that are high risk. And for some of those women, their lifetime risk will be as much as 40 to 50 and maybe even higher percent. So, a 20 to 40-fold increase over the general population. And then there's women who have a family history of ovarian cancer, but no gene identified. And their risk may be slightly elevated. Maybe instead of 1 to 2%, it's 3 to 5%. That's probably some people in there that have that 40% risk, and most people who don't have any increased risk because there is nothing hereditary in the cancer. And so finding out sort of what sort of group of people, general population, family history, gene mutation that somebody is in, that helps define risk.
Right.
But I want to come back to Annie's point a little bit here. So think about cervical cancer, and I always use that as a great model to explain these things. So much of what cervical cancer does is screening. So use PAP or HPV testing, or both of them, to find precancer before it's even cancer, and you treat it. And so it's truly preventative. Whereas something like a low-dose spiral CT for lung cancer is really an early detection test. You're looking to try to find cancer as early as possible, but we're really not focused there on finding precancer. And one of the challenges, as we'll talk about today, is that we don't know what precancer is in ovarian, okay? Right now it's this unfortunate black box. If we knew that, as Deb was alluding to earlier, we could start thinking about interception or detection strategies for primary or secondary prevention to actually prevent anybody from having cancer. And that's the holy grail, right? If we had a choice between early detection and prevention, again, everybody would choose prevention. Nobody wants cancer. And I certainly don't want you to have cancer. So we have to work harder. That's the only answer.
So would you say that that's the similarity between good screening tools like a mammogram and a pap smear, that they're detecting for precancer? Is that what makes them so effective?
Well, mammogram primarily finds cancer early, whereas PAP, and there's a whole bunch of reasons. I mean, we could go on and on and on about that. I think why those tests have been successful, if you particularly for PAP and HPV, is that one, you have a tissue site that you can sample fairly easily, whereas ovarian you can't, right? You have to go in, or you have to view it from the outside, so there are limitations. And in the case of cervix, you have a single cause. It's a single cancer. All cervical cancer is caused by HPV infection. That makes it a lot easier. As Deb is going to talk about, and we'll talk about later, ovarian cancer is not one disease. It doesn't have one cause, and that makes it incredibly difficult.
Yeah,
I can also speak to the CA-125 issue. And for women with ovarian cancer, the CA-125 is actually a very helpful tool for us to follow disease. It's shed from the surface of cancer cells, but it can also be shed from the surface of normal cells. So a normal CA-125 in most women there will be some detectable CA-125 in women without any history, any ovarian cancer. The CA-125, as it turns out, is a pretty good marker for us for women who have disease that has already spread outside the ovary. We don't have trouble diagnosing that. What we want to diagnose is disease that's either has not yet developed yet or is limited to the ovary. And the CA-125 is not helpful in that situation, unfortunately.
Yeah.
So it's a great tool for us when we're managing active ovarian cancer or monitoring somebody with a history of advanced ovarian cancer. Not in all cases, but in many cases, but is not a great screening tool.
And this leads to another important point, which is in screening or early detection, there are some real harms associated with that. And so to Deb's point, doing CA-125 on the general population, there are going to be people who are positive who have no disease, and there's anxiety. And I mean, there's no woman on the planet that isn't going to be terrified of having ovarian cancer when they get their CA-125 positive. And then the steps that go into confirming or ruling out that there's cancer there are fairly invasive. And so we have to think about what we're going to do to the whole population when we make recommendations. And Deb mentioned earlier that there's like a 1% to 2% chance of ovarian cancer in a lifetime. That's what it used to be for cervical cancer before we had the interventions. And why I'm bringing that up is that means that out of every 50 women, if we did nothing to those 50 women, we didn't screen them, we didn't vaccinate them, only 1 out of those 50 would have gotten cervical cancer if we'd left them completely alone. So the harms that we cause in the 49 people who will never get cervical cancer are really important. And so we always have this difficult balancing act of trying to prevent cancer or find it early in the small percentage of people who are going to get it, and doing no harm in those already healthy people who are going to remain healthy. And that is a really tough challenge. It's a fight worth fighting, but understand that there's this balancing act that we are all faced with when we're in the prevention space.
No, and I really appreciate that so much, because again, it's the first thing as a person with ovarian cancer that we ask is, why isn't everybody getting a CA-125? And I used to think it was okay. Let's take 10 people to surgery. We got to save the person with ovarian cancer. And, because of these potential harms, I never really understood that. I never understood the emotional distress until, what's going on with my sister. Because of my history, my sister has had multiple biopsies after routine mammogram and MRI for very small, insignificant findings, and very close together, like twice within a 14-month period. And after seeing what she's gone through, and the terror of just having to go through waiting for biopsy results, the pain. When I think about ovarian cancer and what it takes to diagnose someone is to take them to surgery. And, you've got higher risk, you've got fertility that can be impacted. And now I understand it's, as much as I want a screening tool, it is not okay to expose healthy people to these kinds of risks and suffering. So, what are the principles of screening? What makes a test a good test? What are we looking for? What are the bars that have to be met?
That's a great question. I think we're going to probably get into it, but Annie, thank you for sharing that too about your sister. I think that really helps drive the point home, because we do get asked that all the time. Well, why not just screen everyone? And it does seem simple, but really is much more complicated than that behind the scenes. All right, so let's switch gears a little bit and talk about some very large new studies that have happened recently. Several, but 2 in particular, I think, very large, rigorous studies have been done on screening for ovarian cancer, and they've yielded really important results. Can you tell us about these and what they found? Maybe Dr. Armstrong, Dr. Castle.
So I will just say that we've talked a little bit about CA-125. The other things that we have looked at are imaging studies in general, usually ultrasound. And those have really been kind of the mainstay for us in terms of evaluating high-risk patients, even though we haven't had much data to suggest that they are helpful, even in high-risk patients. And Dr. Cass is going to talk to us a little bit more about some pretty rigorous studies that have gone on over multiple years in very large populations of individuals about the screening that for ovarian cancer.
Right. So the two big trials that I'm sure many of you have heard about is the PLCO, which has now occurred, gosh, almost 30 years, or started with almost 30 years ago. And that was to look at transvaginal ultrasound to identify people with early stage cancer. Unfortunately, that proved to be not effective in reducing mortality. And then the UK CTOX, that you heard about last year. Unfortunately for that study, which is a combination, it's a multimodality approach of using CA-125 plus transvaginal ultrasound, also did not reduce mortality. And we were very hopeful when they had the early readout of that trial in which they had a 20% reduction in advanced cancer. But when we got to the mortality endpoint, there was no benefit. So some of you are probably wondering, well, what gives? Why didn't that save lives? And the problem is that you can find cancers that aren't going to cause death. You can find essentially benign tumors, or certainly in that time frame, those that weren't going to go on to cause death. And so what probably happened there is that 20% reduction in advanced stage cancer were the 20% we didn't need to find. And unfortunately, we didn't shift or downstage the 80% that were the ones that were going to lead to clinically important outcomes like mortality. So it's really tricky. Not all cancers are equal. And in the case of ovarian cancer, as we said, it's multiple diseases that happen to occur in that same area in the body.
So it's actually true then that they found it earlier, but they weren't able to stop people from dying basically at the same time they would have anyway. Is that the gist of it?
Well, what it says is that those 20% were probably not lethal, the ones that were going to cause death. And I'm sure many of you have heard about finding indolent or benign disease, and that's essentially what it is. And that's the part that really, impacts other screening like prostate and even breast cancers, finding disease that, you probably could go your whole lifetime and it wouldn't kill you. But we're still working out how to differentiate the really important cancers from the not so important cancers. And the NCI sponsors a lot of research in trying to make that distinction.
So essentially, you think that are they just different? I mean, I think that's what you're saying, right? Some are just
different.
Some people have something that's never going to progress to the point that it would recur, you would die from it, and then others are going to no matter what.
Right. And so a big area that we sponsor at the Division of Cancer Prevention is studies, biomarker studies, to try to describe those differences on a molecular level so that we can say, when we find a cancer, is this something that we really have to pay attention to? And of course, the other part of that, which I'm sure Deb can speak to better than me, is that as we describe those cancers, it also means that we can tailor the therapy, the precision oncology approach to treating those, so that and whether we're talking about prevention or treatment, we always want to maximize the benefits and minimize the harms, both at the individual level, but also at the population level.
Well, and that really is an exciting development, I think. Precision medicine holds a lot of promise, would you say?
Yes, it does. And we're working really hard. We've got a big division working on that. We sponsor a lot of extramural research to really get after that, but not just for oncology, for actually precision prevention.
Right.
Understanding somebody's genetics, their biology, even their risk factors, and saying we can do a better job of tailoring our prevention strategies to meet your individual risk is essentially the premise.
Got it. Okay, so obviously UKCTOX was a really important study. And while the results weren't what anybody wanted them to be, all that work isn't for nothing. So what has UKCTOX taught us that will help us in our fight against ovarian cancer?
We need a different strategy. I mean, I think that's the cold, hard truth of it. And I share your pain. I share your frustration. You should be mad. You really should be. I get it. We're working hard on this.
The community really does feel angry, I think, when the results were revealed last summer. It was very upsetting. Many people center all their messaging around early detection and symptoms and things like that, which made sense. I mean, it seemed to make sense. And so this was just so confusing.
Right. Well, we all want, we have good screening methods for, for women for cervix and breast, for men and women colorectal, for lung cancer for men and women, and even hepatitis C detection for liver cancer prevention. So we have all these things that, that do work. Ovarian has been refractory, and like pancreatic cancer, right? We're very frustrated about pancreatic cancer. I mean, there's no more lethal sort of common cancer than pancreatic. And it's just for many of the same reasons why pancreatic is so difficult. It's hard to sample. We don't know the natural history. Basically, what we see is healthy people and people with late stage cancer. And that's a big black box that we're trying to dig into so that we can find it earlier or prevent it. But it's a slow go for all the reasons that I said. You can't sample it. It's hard to image it. You find a lot of noise, a lot of stuff that's irrelevant. The prevalence in the population, although it's a very lethal cancer and it causes a lot of deaths, the prevalence, if we walk into the population, it's only going to be 1 out of 100 people, right, of a certain age.
Right. Well, there's a lot of similarities, I think, with pancreatic in that, there's the symptoms are vague. And by the time you have symptoms, typically it's late stage disease. I think that's so similar with ovarian. Annie, I mean, how did you obviously were diagnosed and have several recurrences? Can you talk to us about that?
Yeah, and I think that's part of like the frustration and this focus. We have, survivors and family members who have dealt with this have this laser focus on we need stage 1, right? Because when I think about myself, I had symptoms for 9 months and I pretty much dragged my feet. I ignored them. I'm like, I'm not going to bother, my doctor with this one or that one. It just seemed insignificant. It was my husband who said, hey, you've got a lot of symptoms going on. Maybe you should see a doctor. But I delayed. And I always think, had I gone in earlier and paid attention to these symptoms, could I have been diagnosed at stage 1 instead of stage 2C? Because even though I delayed, it was still somewhat early. Could I have avoided all these recurrences? Could I have avoided all these extra surgeries and the treatments and, the burden on my family taking care of me? I mean, there was a lot of, guilt and frustration. And I know other people, might feel the same way. What could I have done to, change that outcome? And I'm hearing that this is pretty aggressive and it goes to 0 to advanced pretty quickly.
Yeah, it's not clear. It's not clear at all if you'd gone on day 1, whether it would have made a big difference. I think what you're also highlighting is the challenge to prevention scientists is nobody wants to go to the doctor. Okay, I don't want to go to the doctor. Nobody. And we also don't want to go because we don't want to be babies, right? We don't go, oh, my knee hurts, so, I'm going to go and see the orthopedic. No, this will go away on its own. I'm just going to grin and bear it. So, but I don't think people should blame themselves like they have a symptom. It's very nonspecific to sort of say, if I had, that's a rabbit hole. And if you go down that rabbit hole, you make yourself crazy. Nobody knows. Nobody knows whether it would have made a difference. But you did go, and you're alive today probably because of that. So.
Right. So symptoms are important, but perhaps not going to change the outcome necessarily. But it's important to go when you have symptoms. Dr. Armstrong, I know you're a clinician. What do you say to your patients when they beat themselves up about not coming sooner?
Yeah, I think I agree with you. Like, I mean, I have a lot of patients who had, these abdominal symptoms, and then they get diagnosed with ovarian cancer and they still have the symptoms. It wasn't the ovarian cancer that was causing the symptoms, it's other issues. But I agree that kind of, oh, what if I had done this? I don't think that's helpful. I don't think it doesn't improve outcome. It doesn't improve your ability to tolerate treatment. And so I think that's, it's probably human nature, but I don't think it's helpful.
Right.
But the symptoms do help us, in absence of a screening tool or any other test, they may help us get to a gynecologic oncologist to get the treatment that may help.
Absolutely. I think it eases psychological distress to a certain degree. You know there's something wrong with that diagnosis.
But, I mean, I think that these symptoms are so non-specific. I'll give you an example of my wife. And I do want to say that cancer is very personal to me. Even though I'm not directly a cancer survivor, I am a cancer survivor because it's been entirely it's devastated my family. Lost my mother at the age of 35 from brain cancer. My wife at 56 from endometrial cancer. My father at 78 with sarcoma the year later after my wife passed, but he was the most healthy 78-year-old, except that he had cancer. I mean, he would out-hike people that were 30 years younger than he was. So in the case of my wife, she had spotting and blood, and she never said anything to me. And it went on, and then she finally went to get an ultrasound. They saw a mass. Even then, they thought it was, a borderline ovarian tumor. And then when the doctor went in, they found stage 4 endometrial cancer that had invaded her colon. Mm-hmm. And so it's really hard to, the individuals, and partly they don't want to complain. They don't want to, everybody's so busy and it's easy to go down the what if path, and it's not productive. And people shouldn't blame themselves and they shouldn't blame others. It's like, okay, if you want to blame somebody, blame us for not coming up with a better strategy. Okay. So, and we're working on it. I get it. So, but I just want everybody to know it's really personal to me, and I am working as hard as I can to move us forward.
Well, I appreciate you sharing that with us. It is definitely personal, I think, for a lot of us. Do you think, let's talk about hope on the horizon. I mean, we hear lots of things about other tests and things coming out. What about these liquid biopsies that are coming out now with the multi-cancer detection tests? I think they're even being marketed to the public for some cancers, not ovarian. What do you think about the future of those?
Well, I have to look at it in a balanced kind of way, because so let me just explain what those are so everybody's on the same plane here. So for probably a decade, there have been these things called liquid biopsy tests. And the liquid biopsy tests have been primarily in the oncology space to monitor therapeutic effectiveness for people diagnosed with cancer. And the idea is that there are molecules, biomarkers that are in blood that are shed by the cancer that can be detected. And blood's easy to collect, and it's pretty homogeneous, so it makes the testing part pretty easy. And those have come along quite a way, and they're part of pretty widely used in the sort of standard practice for oncology. About a half a dozen years ago, people started to think, well, maybe we can use it for early cancer detection. Okay, and so now there's probably about 40 of these tests out there. We know about more than 24. Okay, but there's probably other ones that people are working on, plus academics are working on this. And the idea is, could we find those signals earlier, before there's actual symptoms? Now, so there's a lot of hype and there are a lot of advantages to the multi-cancer detection, because the prevalence of multiple cancers is much higher. So, you may find something that if you were looking for one cancer, you wouldn't find. There's also a lot of, so there's a lot of hype, a lot of hope. Okay. And the bottom line is screening and early detection needs to save lives. It has to be clinically useful. Just being able to detect cancer is not inherently helpful, right? It might be, but you have to show that detection leads to reduction in mortality. Just like the UK CTOX trial, they found what looked like a signal that they could find cancer earlier, but that didn't translate into a mortality benefit. So as exciting as these multi-cancer detection tests are, we have to put them to the test. We have to evaluate them rigorously. I think it's, we have to be, we at the NCI have to take a very sort of agnostic view of this and say, as public servants and public health scientists, we have to evaluate, we have to make sure. And that's just the benefit part. So what are the harms, right? So we're really talking about cancers that are not like cervix and stuff that are easily sampled. So the diagnostic pathway and the verification of the cancer could be quite invasive. And then the other problem that we worry about, or one of the many problems, is will, in the process of validating these technologies or as they're introduced, will people stop doing their standard of care effective screening, right? Because they say, oh, well, my multi-cancer test is
It's
negative.
covering everything, right?
Right, or even my multi-cancer test is positive, it found something. That means I don't have to do these other ones because that's probably the cancer that I have, right? There's all sorts of issues around this, but like with anything, like if we were talking about a drug, we would never put a drug into somebody without evaluating its benefits to harms. This is not different. Even though the test itself is external, you get blood and you send it off to the lab, the downstream consequences are internal, right? You're doing a biopsy, you're doing some sort of invasive procedure that has some real harms associated with it. The other problem is that right now, we don't know if these tests work equally well for everybody, right? We don't know how these tests were developed. We don't know if they, in fact, will work well in underrepresented minorities and other populations. And that's really important. If we really are committed to health equity, and I am, I mean, the last 20 years I've spent on working on cancer health disparities, you know, how they fabricated the tests may, you know, may influence whether the test works the same for everybody. And then there are some people who aren't going to be able to afford these tests, okay, because they're not insured, they're not, or they can't even afford the copay. So are these tests going to really be available to everybody? Are they going to help everybody? And do they actually work with a minimum of harms? Now, all that has to be sorted out, and we need to do a rigorous trial, which we're planning to do.
And you know, the issue of liquid biopsy comes up a lot, you know, for patients because they read about it on the internet and things like that. And I think, you know, it's worthwhile to just sort of step back and sort of say, what exactly is a liquid biopsy? And as Dr. Castle said, it is a blood test, and the blood test looks for circulating DNA molecules. And those can come from our normal cells as they die, in particular white blood cells. They can also come from cancer cells. And when we started doing this, we were doing this primarily in patients with advanced cancer, where we wanted to know what are the markers in that cancer that we can use to direct therapy there. So it was really a treatment issue. You know, is there this mutation that we can target? And so that's really where it started. And then people recognized that you might be able to actually follow somebody who had had cancer and was at risk for a recurrence and look at their cell-free or circulating tumor DNA and see if there's evidence of the cancer there, which might predict a recurrence. And then that sort of has led to the hypothesis that maybe we can use this as a diagnostic test for somebody who might be at risk for cancer and is developing cancer. And as Dr. Castle said, that's a big leap. That's a big step. And that's going to be a much harder thing to prove is beneficial. I think most of us, you know, feel that there may be, our body may be fighting off cancers all the time. So if you detect some cancer DNA, does that mean you're going to get cancer? Does that mean your risk of getting cancer is higher? What is exactly that risk? Which cancer is it? And those are things that have to be answered before we can start using this as a diagnostic tool. And I think the ways that we have seen cell-free DNA or circulating tumor DNA or liquid biopsies be helpful have been a little bit easier already, but using this as a tool for screening and diagnosing cancer that's about to form or about to be problematic is going to be a much bigger leap.
So just to add on to what Deb said, the technology is evolving very quickly. And so now this next generation of tests actually doesn't just rely on DNA, it relies on epigenetic or what's called methylation. Some of them have proteins, some of them will have RNA, so a variety of biomarkers. And so the real hope, you know, the first generation tests, we don't know how well they work, but I think people are working on this and they're going to keep refining it. So maybe the first generation works or doesn't work, but maybe the second generation does. But we have to do our due diligence. We can't let this stuff out into the public, hopefully, without knowing whether it's gonna work. And the other thing is each of these tests, and like I said, there are many tests in development, they target a different group of cancers. So which one is best for you? I don't know, right? Which one is best for you? Which one is best for you? That may vary, okay? So a BRCA carrier may benefit from a different test because it happens to focus on ovarian and breast and pancreatic, right?
Right.
Whereas a Lynch syndrome Lynch carrier might benefit from the one that is more focused on colorectal and endometrial. So if they work, right? So, there's a lot of complexities with this that we've never experienced. And we have a big team at the NCI working together across the NCI because we've never dealt with anything like this. So this is all undiscovered country. We're learning as we go, even how to design the trial, what makes the most sense. We don't, a lot of questions about trial design for something we've never, because up till now, it's been, one test, one cancer, one test, one cancer. So now we have this whole new field, essentially.
Well, exciting in that it's progress, but maybe just not there for ovarian cancer yet, at least, and perhaps other cancers.
Well, we're hoping, but
Yeah.
we gotta do our work.
Right, exactly.
I think it's very exciting, and that to hear of the pioneers who are, working so hard to get these new technologies to us, and also the pioneers who are trying to vet these new technologies almost in real time. It's quite, my brain is like exploding at the math that's probably having to happen behind it. And, in addition to what's happening in the liquid biopsy, multi-cancer early detection area, are there any other interesting early detection work for ovarian cancer in progress, or things that are kind of getting some, some excitement generating?
Well, I'll be happy to take that on. Annie and I have worked together for well over a decade now on the Department of Defense Ovarian Cancer Research Committee that very fortunately that the survivor group has allowed that to increase funding at least fourfold over the last decade, from 10,000 to 40,000, 10 million to 40 million a year. And we have created actually, and this was a priority for this ovarian cancer research approach, to actually look at specifically at this kind of molecular, which we call omics, which could be proteomics, looking at proteins, genomics, looking at genes, a whole variety of approaches to try and look at ways to screen for ovarian cancer. And we actually have prioritized this being a consortium, meaning it's not just group A or group B doing this, but we want them to work together, which increases the power of being able to do studies. There are also studies going on, for example, through our ovarian cancer spore, looking at using the technology that Dr. Castle was talking about, looking at DNA markers in the pap smear. We have decades of experience looking at pap smears, but they have been largely for cervical cancer. But could 1 in 1,000 cells from the endometrium or from the fallopian tube or the ovary be in there and be a way to detect ovarian cancer? And so there's tools now that we're looking at, and largely, at least initially, looking retrospectively at large populations that have had these tests and looking to see whether we can identify markers in that pap test, hopefully years before somebody develops cancer. So those are very exciting. There are also other tools such as the falloposcope, where a surgeon can insert a scope through the cervix, the uterus, and into the fallopian tube to both visualize it, but probably more importantly, to capture some cells to see if there's precancerous lesions. And we haven't talked about this today yet, but we think that probably at most, well over 50% of what we call ovarian cancer actually starts in the fallopian tube. So I think, there's lots of excitement out there in terms of early detection. And most of it, again, will not be in the visualizing something abnormal. It's going to be looking for the cells or the markers of the cells that are cancer or precancerous.
I'm sorry, Annie, go ahead.
No, Dr. Armstrong, I'm so glad you mentioned, the thing about the falloposcope, and we hear a lot about sticks, that are the little lesions that are at the tips of the fimbria, which may be the beginning of ovarian cancer. And in my lifetime, or my ovarian cancer lifetime, is when we discovered that not all ovarian cancer started in the ovary. And so a lot of these tests that came before, and even when UKC Talks started, the understanding was that ovarian cancer started in the ovary. And, this new paradigm within the last, 10, 12 years or so, so that's still somewhat brand new knowledge in research timelines, and so I think shifting to that, as well as, I think one of the things I was with the TCGA, the Cancer Genome Atlas, which is also somewhat newer. It's been around a while, but I remember seeing how complicated ovarian cancer was compared to the glioblastoma, where all the mutations kind of lined up. So I think it just brings to home to me on how important research is to really understand what the disease we're looking for, that we're wanting to screen, that we're wanting to save lives with. Because without that research, we can't move forward. And another shout out to the advocate leaders and everyone involved who helped increase the funding at DoD, because it's that really drives things forward.
So let me add a couple things. I also want to, support President Biden's initiatives around prevention and screening, and I'm hoping that will trickle down to, expanding the research and prevention, particularly on ovarian. The NCI does a lot on biomarker discovery for ovarian cancer. We also, we do a lot of work on developing new preventive agents or repurposing preventive agents, like we're now exploring, first and second generation PARP inhibitors and BRCA carriers. And so it's a work in progress, right? And we're looking at different strategies: primary prevention, secondary prevention, interception, early detection. It's a full court press on this. But let's put it in perspective, and this sort of builds off what Annie was saying. So in the early 80s, we discovered that there was human papillomavirus and it caused cervical cancer. It took 25 years from then to come up with a vaccine. And remember, cervix is unique. It's kind of the low-hanging fruit because we have a single cause for a cancer, right? And this is not going to be that, right? So it took 25 years. And to Annie's point, we're still trying to understand the basic biology of ovarian cancer. So we're almost at time zero in some ways. I mean, we know it's not quite that bad, but we're still learning about the biology that hopefully will lead to an understanding that will lead to strategies. But it has to be based on science. We have to build it's a foundation from which we can prevent, we can better manage the cancers, and hopefully cure some of those cancers as well. So,
well, to make it even more complex, then you have the ovarian cancer is so heterogeneous anyway. So you're talking about a lot of different cancers as well.
Right, exactly. So even when we had it all lined up, we knew what we were going after. It took 25 years to get an FDA approval for an HPV test and 25 years to develop a prophylactic vaccine. Okay, and that was under the best circumstances. So I know that's not happy talk in terms of timelines and everybody wants something yesterday, but I think, we have to have some realism here, unfortunately, so that we don't raise expectations beyond what they are. Now, who knows? Multi-cancer detection tomorrow, one of them may show that it works, and hallelujah, we'll all be dancing in the streets. But
pack up and go home. That's okay.
Yeah, we're happy with that. If somebody can put me out of business,
Absolutely.
I'm perfectly happy with that. Okay. But until then, we have to do our jobs and we have to work hard and we have to trust but verify, right? So we have to do our due diligence.
But I will say, this issue of what we have learned, over the last 10 to 20 years, I think the fallopian tube etiology issue is one that, has allowed us to actually move forward a little bit. First of all, we found that first of all, we've been taking out normal ovaries for women for decades as they had hysterectomies, and we couldn't find a precancerous lesion on the surface of the ovary. But when women with the BRCA mutations who were having their fallopian tubes and ovaries removed as a prevention, lo and behold, what we saw was the ovary might look fine, but the fallopian tube didn't always look fine. And that's really where we started to see this whole issue of, yeah, maybe the fallopian tube is the etiology. And, if you think about it, the ovaries here and the fallopian tubes here, and its job is to sort of basically stay at the surface of the ovary. So when the eggs, when the ovulation happens, it doesn't go flying off into the peritoneum, it goes into the uterus. That's, that's its job. But there's literally, probably a million, 10 million, 100 million more cells on the fallopian tubes because it's got all these finger-like projections than there are on the ovary. And because it's a thin-walled organ, when cancers form, the cells just float off. Well, they're going to land on the ovary, but they're going to go floating out into the peritoneum as well. So, identifying the fact that the fallopian tube is the cause of a lot of what we call ovarian cancer has been a major, I think has been a major improvement in our understanding. But it may lead to prevention that ultimately might decrease ovarian cancer mortality. So, for example, women who used to have their tubes tied, a tubal ligation, are now recommended to have their tubes removed. And that really is not a more complicated procedure. You still have to have an anesthesia, but that's a very common procedure. And removing the tubes is really not much more complicated than tying them. And so that's called a salpingectomy, removal of the fallopian tubes. But a woman who's having a hysterectomy for fibroids, sometimes they didn't have their ovaries removed. But those women are now recommended to have their fallopian tubes removed. And even in very high risk women, like our BRCA mutation carriers, a woman who's 35 is done having children, but finds out she has a BRCA mutation, may not want to go into menopause by having her ovaries removed at age 35, but she can have her fallopian tubes removed. And then as she approaches natural menopause, when the medical consequences of menopause are going to be less concerning, she can then have her ovaries out. And so this is an approach now that we can use that may ultimately result in a lower incidence of ovarian cancer.
Right. We've been talking a lot about it, opportunistic self-injectomy.
Yep.
Taking advantage of a surgery that would be going in anyway and taking out the tubes. I think we're very excited about that as a possible preventive measure. Would you agree?
Oh, absolutely. And, again, that 35-year-old woman who's sort of stuck with, oh, do I take my ovaries out and go into premature menopause? Do I want to do that right now? Or the woman who's 35 and is not sure she's done childbearing. Right. She may be able to harvest eggs, take her fallopian tubes out, and then have future children through IVF. So there's lots of, this information is really, I think, in the last 5 to 10 years has really kind of changed our approach. And I hope will change and impact the ovarian cancer incidence and mortality.
Well, and this comes back to that earlier comment, which is the benefits to harms, right? So here, a perfect example, the benefits are going to be the same, but we're reducing the harms. The quality of life is better. You don't go into premature menopause. You retain, potentially retain fertility. I mean, there's lots of good things that can come out of even taking what looks like a baby step, not from a surgical perspective, but that just narrowing down where the problem is and removing that has an important improvement in quality of life. And it is, when we're dealing with healthy people, that quality of life is really important. We have to place a tremendous amount of weight on that because they are healthy until they're otherwise. So, and I think we have a trial, DCP has a trial that's looking at removing both versus moving the fallopian tubes.
And I think, oh, sorry.
I just wanted to bring the thing that something that Audra spoke of is that, the ovarian cancer monolith is not one disease. And so, the advanced cancers are mostly high-grade serous carcinomas. And, but, early ovarian cancers, we see much more endometrioids and clear cells. Low-grade serous cancers function differently, may be responsive to hormonal manipulations, and have a precursor of these borderline tumors. So there's a variety of different kinds of ovarian cancer. And then we haven't even talked about the germ cell ovarian cancers, which aren't epithelial. And so, I mean, it is not a simple thing from our perspective, that it really is multiple diseases.
Well, Annie, I know you're probably going to take us home and we're going to talk about some, where do we go from here? What should we be focusing on? But before we do that, I just want to talk one more time, and I don't mean to keep going on about it, but in terms of the UKC tox trial, I think it clearly showed us that the disease was diagnosed earlier, 18 months prior, I believe, to the onset of symptoms, clinical diagnosis. And yet there was not there were stage shifts, but there was not a mortality benefit. So I'm just reiterating that, but that doesn't mean, and I'm going to ask both of our doctors, that doesn't mean we shouldn't pay attention to the symptoms. Is that correct?
I would say absolutely. I think any woman with new symptoms should have them evaluated, especially if they're persistent, especially if they are interfering with quality of life. Many women attribute some of these abdominal symptom changes to menopause, and they may or may not be related to that. And I think, every woman deserves to be heard about the symptoms and problems that she has, and those should be looked into. It may be simply following those up. It may be doing an investigational intervention, but I'm not saying that they shouldn't be looked at, but most of the time, these are not going to be ovarian cancer.
Right. I think that's the important point is just because you have symptoms, you have what appears to be irritable bowel or something else, don't equate that to having ovarian cancer. Something's going on, may or may not have, likely it doesn't have anything to do with ovarian cancer. And I think that doesn't mean you shouldn't get it taken care of, but it needs to be right sized, if you will.
For us, it always comes back to messaging. In the old days, we might say, knowing the symptoms could save your life. And that's actually just not a true statement, I think, at this point, based on this research. And yet, knowing the symptoms can get you a diagnosis quicker, which is psychologically helpful. I think, Annie, you talked about that. It could make, I think, your surgery a bit easier, I would assume. So there are reasons. We don't want anyone to think we're saying don't know the symptoms. So I just wanted to reiterate that. However, focusing on saving lives through symptoms, I think, is the wrong message, because there are so many other great messages. And that's what I think we want to talk about. Annie, I'll kick it over to you. Sorry.
I'm just thinking about, our messaging about the symptoms and all the wonderful groups who are doing great work spreading awareness. And there was a time right after the consensus symptoms came out where the messaging was consistent.
Right.
Here are the core symptoms, and here are some others that can do. But I think it was really helpful because it's those GI symptoms, the abdominal pain, the bloating, that distinguish it from the other gynecologic things that could be happening, and other things, but the things that happen in tandem. And but because everyone's symptom card since then, it's been 17 years or so since that came out. And so every symptom card looks different. Here are my 3 favorites, and so, so our community across the board has, it dilutes the message and usefulness of the symptoms.
So OCRA is actually going to develop a template, Annie, thank you for saying that, for people, if they'd like it, a free template, so we can standardize the messaging based on the results of UKC Talks and kind of incorporating all this.
Yeah. So, we've covered so much, and, we know that a lot of effort has gone into, early detection. We know that there are high bars required for any screening tool. So where do we go from here? What should our communities be focused on going forward?
I can tell you what OCRA is focusing on, and what we've been working with a lot of community members, and we have what we call community partners, which are about 80 plus organizations around the US and the world that are working on the same thing. So we hope through this we can kind of standardize the message. And what is our message? We're going to promote genetic testing for at-risk populations and encourage people to take action if they obviously find anything wrong. Encourage people to have surgeries, like we talked about the opportunistic self-injectomy, if you're already having a surgery. Continue educating about the symptoms for the reasons we discussed, not to say save lives, but to get a faster diagnosis and have ease, I guess, of treatment. We're also going to encourage other organizations to standardize the messaging, which is kind of what this is all about. We want to educate everybody as to what to do when they get if they're diagnosed with ovarian cancer, which would be see a gynecologic oncologist and make sure that they're receiving standard of care, These are very important messages for us. And we hope that everyone will utilize genomic testing as well so that they can receive personalized treatment. So that's been part of our educational campaign, is to make sure people know about that and to encourage cascade testing for family members of patients as well. And finally, we're going to urge, and we do urge, every patient to explore clinical trials. That is just so, so important. So that from our perspective is where we're headed. I don't know if anybody has anything to add.
No, I just want to reiterate the participating in clinical trials. It's always a struggle to get people onto clinical trials, both for prevention and treatment. Certainly COVID has made that more difficult. We can't get across the finish line without people participating. That's just and particularly, with an eye towards, having representative populations on those clinical trials, so that we know with confidence that the things we're developing are going to help everybody and not just a select few. So we need your help. We can't, this is a partnership. We can't do this alone. We can come up with fancy tools and stuff, but we can't deliver those fancy tools without your help. So
that's right. And we're definitely going to partner with you on that for sure. Dr. Armstrong, do you have any last thoughts?
I would just say this has been my life's work is clinical trials, both therapeutic or treatment clinical trials, but wearing my hat as in the genetics clinic of people who are at risk joining registries so that we can follow and track what happens with them, participating in clinical trials for prevention if that's appropriate. As Dr. Castle said, this is how we move the science forward. And so I think I encourage my patients at every step of the way, ask about a clinical trial. There may not be one that's right for you now, but they may be one down the line.
We are beating that drum. We tell every single person we talk to, for sure. So as we wind up today, I wanted to ask you, Annie, as a long-term ovarian cancer survivor and someone that understands the research so well as you do, what do you make of all of this that we talked about today? And how does it make you feel for the future?
Yeah, so I'm gonna put two hats on right now, and first is my research advocate perspective, and I think what I've learned along the way, and even more today, is just how complicated ovarian cancer is, and how we're just beginning to learn a lot about it. The high bar that is set for any screening tool to be vetted. I have a great deal of gratitude, just to have this conversation today with Dr. Armstrong and Dr. Castle and you, Audra, and to all the doctors and researchers like Ian Jacobs and Usha Menon, and everyone who's worked hard, really, really hard to try to get us screening and early detection, and those who are continuing to work hard, because despite how hard it is, they're still doing the work. And it just gives me a lot of hope. And, that we need more research, we need more basic science, and we need more clinical trial participation. Putting on my patient hat, it's still on my heart. We need to protect the people we love and the people we don't even know. And how do we do that? And until there's a test, and we've got the symptoms, but we really, getting more consistent, returning to the core symptoms and the constellation of symptoms would be helpful. And we need to continue to raise awareness about the risk factors, about the need to get genetic testing. And when there are opportunities to reduce risk, let them know this is the way, because we know that reducing risk has saved lives and can decrease mortality. And it's just more science to get us to the next step.
Absolutely. And I just want to reiterate, negative results are results, and they've certainly pointed us in the right direction. And as I also always say, we can't stop, right? We're going to stop doing research. We're not going to stop. We're never going to stop until we find a cure. So I just wanted to thank you all so much. This has been a great discussion, and I think a really, really important one for our community. I would recommend that anyone watching today that would like to discuss this further, reach out to us at OCRA. I know it's confusing. It's hard to kind of understand all the different words, and I get confused, the screening versus this versus that, but we're happy to sit with you and talk through what the results were, what this means. We very much see our role as ensuring that research will keep moving forward, and it's an important part of working closely with all of you in the community. So thank you again to our panelists for lending us your time, and thank all of you for joining us today.
I hope you found the conference meaningful and are leaving with new information and perhaps some new goals. Whether you decide to participate in a clinical trial, get more involved by raising money for research, apply to become an advocate leader, Join one of our support groups or partner with one of our woman-to-woman mentors. There are so many options. Please remember that OCRA is here for you. Call our social work team, take advantage of our resources, join an online support group. There are so many ways for us to connect. And if you haven't already, follow us on social media and sign up for our e-blast to stay informed about our new initiatives, as well as the latest research, health legislation, and support services. We are so grateful to each and every one of you for joining us this year for Ovarian Cancer Research Alliance's Uniting for Hope National Conference. And a special thank you to our presenting sponsor, GSK, and all of the companies whose support made this conference possible. If you take away even just one thing from these last few days, take away hope. Know that we're here and we're working to stop ovarian cancer every single day. We're here for you and your families with whatever you may need. You're not alone. And joining this conference with hundreds of survivors and loved ones will hopefully offer you a renewed purpose and a path forward. Thank you again for lending yourselves to us. You inspire us each and every day. We'll see you next year.